think I'm going to get started just with the intros in the interest of time. So just starting, just thank you so much and good afternoon, everyone. Thank you for joining us today for our webinar panel on social work perspectives on advanced care planning and aging. My name is Katie Bisaha, and I am both a program officer at the New Jersey Healthcare Quality Institute, as well as a Rutgers dual MSW and MPH student. So I'm really thrilled to co-host this session along with Dr. Lauren Snedeker and our incredible panel and speakers. This webinar is a collaboration between the Hub for Aging Collaboration at the Rutgers School of Social Work and the New Jersey Healthcare Quality Institute through our statewide initiative called the Conversation of Your Life, or COIL. And just before we begin, just a few housekeeping notes. Please feel free to stay muted unless you are speaking. You can use the chat for any questions or comments that you wanted to add. And we will have time for Q&A toward the end of the session. And since we have a larger group, I just ask that you reserve those questions for that section, just in case your question is also answered while our panelists are letting you know about their experience and such. And when we do get to the Q&A, you can either type it in the chat or you can come off of mute using the raise hand feature just to make it easier. And then just a little information about who the Quality Institute is. We are a nonprofit independent organization that brings together providers, payers, community leaders, and policy experts to improve the quality, safety, and affordability of healthcare for everyone across our state. And one of our flagship community health programs is the Mayor's Wellness Campaign. And so we work with over 400 New Jersey municipalities to create healthier environments for their residents and make health and wellness a cornerstone of their community. And this is just a little bit about COIL. So within that Mayor's Wellness Campaign, we lead COIL or a conversation in real life. And this is a program that's designated to empower people to discuss, document, and share their healthcare wishes. And COIL focuses on making advanced care planning part of everyday health and wellness. And we do partner with social workers, health providers, faith leaders, librarians, attorneys, and other community advocates to create spaces where people can talk openly about what matters most to them. And I just wanted to kind of pull together why advanced care planning does matter in social work practice, right? So as social workers, we are already having these kinds of conversations, or we're gearing up to learn how to have them. And we do that almost every day, whether it's about our values, our fears, family dynamics, and what's most important to the people that we do serve. And so advanced care planning isn't something separate from that. It's really an extension of what we already are doing well. It's about helping people make choices that reflect who they are and how they want to live, even in times of serious illness or uncertainty. So through COIL, we do try to make that a little bit easier. So we give communities and professionals language, resources, and a supportive network for these discussions. So when social workers do lead these conversations, it really does help clients feel seen, supported, and confident that their wishes will be honored. And we're a really valuable part of that interdisciplinary team. So that's kind of at the heart of both social workers and good care. So that's why we're having this conversation today, or part of it. And so I am going to send it over to Lauren, who's going to introduce our panelists and the event. And thank you so much.
Thank you, Katie. Just give me a thumbs up that you can hear me. Fantastic. Thank you all so much. It's such a joy to see you all here signing in for this important conversation. I'm very excited to just reiterate what Katie mentioned in terms of the importance of social workers really taking the lead on advanced care planning. We balance both the practical, logistical understanding of this work, as well as the emotional, mental health, and family history of this work. We hold it all, and I know that we're all doing a wonderful job. And the space today is dedicated to a panel of professionals practicing in community, in agency, and privately to share remarks around advanced care planning from their positions in social work practice. So we have Joan Ordille, if you could give a wave, Joan, and they could definitely share a little bit more about their work as they're answering the questions. Let's see, I'm looking for other people. We have Molly Fisher, if you could give a wave. Yeah. And we have Tracey Arnauer as well. Thank you so much to our wonderful panelists who, again, all represent a different aspect of professional social work practicing in private practice, direct practice, as well as community and agency work. So before we get started with the panel questions, Katie devised a wonderful icebreaker component that we'd love to go ahead and start. So we're asking folks to participate in sort of a myth fact game around advanced care planning. And so what you could do after I ask a question is either virtual thumbs up, thumbs down. Please feel free to have other reactions that are appropriate and kind, as well as any remarks in the chat that you would like to add for each question that I go ahead and pose to our group today. So the first statement, if you will, is if I name someone to make decisions for me, I give up my right to make my own decisions. Would we say this is true, false? Yeah, very happy to see all my students answering this question correctly. Right. So this does not mean that we give up the rights to make our own decisions. And we'll talk more about that as we go through the panel. The next question is, advanced directives must be completed by a lawyer and notarized. Let's see. What are we thinking? We're seeing some no's. Yeah, our panel professionals are saying no, and they'll be able to talk more about this. Advanced directives, our next question. Advanced directives are legally binding, so the healthcare team must follow them. What are we thinking? And these, are complex questions. Complex. We're seeing some thumbs up. Right. So we're going to get into this further, but I think it's definitely complicated. I'll say that. Once I complete an advanced directive, it is good for the rest of my life. Interesting. Dr. McCoy, one of our wonderful faculty members of the School of Social Work, says no. Others are saying yes. So we're definitely going to have opportunity to reflect on all of these questions. One of my favorite questions as the director of the Aging and Health Certificate Program at Rutgers School of Social Work is, advanced directives are only for older adults. Calling in for my Aging and Health Certificate students. Oh, great. Overwhelming no. Thank you very much. Thank you very much. Let's see. I don't need to talk about it with my loved ones. They know what I want. Thanks, Noni. Thumbs down. Wow, this is great. So we're going to be in a really wonderful space together. And panelists will definitely clarify and expand on all of these questions and answers in just a moment. But thank you all for indulging us in this kind of true or false, myth or fact. So now we're going to go ahead and, oh, I wasn't checking the chat. Is there anything exciting that folks? Yes, absolutely not. No. Okay, great. Awesome. Thank you all so much. So now I'm just going to go ahead and welcome our panelists again, and just to be mindful of time. As the panelists speak, you can just share just a little bit about where you're coming from, where you're joining from, because I did sort of loop everyone in together. But as I mentioned, we have hospice and palliative care team represented. We have community-based social work represented, and we also have private practice social work represented in our panelists. So I'm going to go ahead because we have a lot of really great questions. I'm going to go ahead and ask the first question of our panel, and we can certainly go in order, whoever feels, like they want to answer first. And we're in the middle of spotlighting our panelists now. Thank you so much. So my first question is, what does advanced care planning include, and how does it show up in your work? Molly, you came off mute, so I'm going to do the professory thing and invite you to go ahead and answer first.
That was purely by mistake. I'm sorry. I was trying to figure it out. I need you to repeat the question.
The first question that I have for our panelists is, what does advanced care planning include, and how does it show up in your work?
Okay. So my name's Molly Fisher. I'm a psychotherapist, and I primarily focus my practice on working with caregivers. Even more specifically than that, caregivers of individuals who are living with varied dementias and Parkinson's disease. So advanced care planning in my work as a private practitioner is oftentimes with the caregiver and helping them kind of reconcile any feelings that they may have about the advanced care plans that their person has chosen, or they're just feelings in general about talking about end of life. So a lot of conversations, a lot of feelings, a lot of processing. I destigmatize things as I can. I refer out to elder care attorneys, to the palliative care and hospice social workers in the hospitals that their people might be connected with, geriatric care managers. So all of that concrete planning can be done, and things are kind of set before we get to a crisis point. And then I continue to work on the feelings.
Thank you so much. Joan, did you want to go next? Thank you so much.
So in the hospice setting, advanced care planning could include several different things. An advance directive or a POLST. In addition to that, financial power of attorney, having a healthcare power of attorney named, which is often part of doing an advance directive, but not always. Sometimes people include that in the financial piece and don't do a healthcare. So sometimes just for people who are doing this, it can be really confusing. What pieces should I have? The other piece that occasionally came up in advanced care planning was having a funeral agent. If someone does not have, if someone is concerned that people are not going to carry out their wishes after they've died, having a funeral agent, and that actually does need to go through a lawyer from what I understand, can really help to make sure somebody's after death wishes are carried out. So for us there in hospice, there was often several aspects to it that people were a little bit confused over.
So a lot of, psychoeducation and understanding around the different types of paperwork and things that needed to sort of begin.
Providing forms for people sometimes, walking them through the process, and validating for them often that this is hard. This is hard. These are hard conversations to have, but they actually are empowering conversations as well to ensure that people are going to have their wishes respected.
Thank you so much, Joan. Tracey?
Yes, hi. Thanks for having me. I work as a hospice and palliative social worker at Holy Name Medical Center, which includes both community palliative care and inpatient palliative care, community hospice and inpatient hospice. So I also forgot the question though. I'm sorry.
We've all got a lot going on. Thank you so much for everyone being here, and especially to our panelists. And the question is kind of just starting us off, right? Like, what does advanced care planning include? And this is unique to each person on our panel. And how does it show up in your work?
Okay, so just a lot of similarities to what Joan and Molly already shared, but just to add a little bit of a different perspective is oftentimes in the community, as the social worker on our team, our palliative team or hospice team, I might be one of the first healthcare professionals to bring up this topic. And I find that families are often a little bit nervous to talk about it, maybe think they don't need to talk about it. I often hear things like, oh, my mom knows what, or my daughter knows what I want, just ask my daughter. I don't want to talk about this. Or even families protecting an elderly parent saying, oh, we don't want mom to know that she's dying. We're just going to make these decisions for her. And I just see a lot of really well-intentioned families trying to protect one another from what can be a very emotionally difficult conversation. So it really makes me feel very excited to know that as the social worker stepping in for the first time, I'm really going to make an impact by providing a lot of education. What are advanced directives? What is it even that we're talking about?
and really like simplifying, where do you want to be when you're getting your treatment? Do you want to be in an inpatient setting or home? Who should be taking care of you? Is it going to be a family member or a paid caregiver? And really just breaking down what is important to every day in their quality of life day to day. So I feel very, like Joan was saying, it's very exciting to know we can empower, educate our families and patients, and empowering them to make informed decisions that are really going to have a meaningful impact on how they're living through their illness.
Thank you so much to all three panelists. One thing that stuck out, Tracey, which I think is very helpful, especially for folks, whether they've been in the profession for many years or students and currently thinking about this area of practice, is a lens of the good intentions of family members, because the situation you mentioned earlier was around an ethical dilemma that we all might face in our practice, where family and friends and loved ones might not want explicit details shared with the person out of protection, out of care, out of concern. And we have feelings inevitably around those decisions. But I think approaching those experiences, understanding that there's good intention behind that, is a really good first step in exploring strategies to support that person and family. So I appreciate that. I want to move into our next question, if you don't mind. Oh, actually, I had one more comment. Many of you spoke about oftentimes usually being like the first professional, maybe and person, for bringing up this this care decision, this point of life, this experience. And so I think that's also very important to just honor and acknowledge that many people, unfortunately, might not think about advanced care planning until there's a certain event that happens to them or someone they know. And so that's kind of the purposes of today as well, to kind of have these conversations in a more natural and supportive and curious manner before something kind of forces us to do so, and then we're making decisions in a time of crisis, which I don't know about you, but I'm a social worker, but like crisis is hard. So my next question to the panelists, in no particular order of our panelists, but how do you initiate conversations around advanced care planning? Maybe getting a little bit more specific, especially for folks who've never approached this with clients or families in a way that builds trust and confidence. In social work, we're talking always about engagement. We're talking about building rapport. We're talking about all these types of things that support the therapeutic alliance. And so I'm just curious about how to initiate.
So I just think it's important, as social workers, we start where the client is, and sometimes they aren't ready. So I think that we introduce, in hospice, it's generally at least asking questions about the presence of advanced directives and other advanced care planning paperwork is a normal piece of that assessment, but we have to pay attention to what the family and the patient want. But I think we also are really facilitators of conversation, because, as Tracey said, so many times out of care and concern, a family member doesn't want you talking about death and dying, don't say the word hospice. But honestly, the patient knows. They know generally. They're living this reality. They've lived through decline. And so being able to, again, meet the family where they're at, but be able to help them to have conversations, because these are hard conversations for them to have without somebody who is not so emotionally attached facilitating.
And I'll add to that. Thank you so much, Joan, for starting where all social workers should start, right? Like where the patient is. A lot of times I will, Usually, and then oftentimes people are coming to me because they're caregivers, they're burnt out, things are changing for the person that they're caring for. So these conversations might already be in their world. And it's interesting to see for those of you who are thinking about private practice, right? The deep clinical work that's here, which is there, all the different stages of grief and the denial, and this isn't happening. And we're going to go through all the studies and there's going to be a breakthrough. And listen, I'm hopeful, but also I'm realistic in that while we're waiting for a cure, what is the action that we can take now? And whereas a husband might not want to think about life without his wife after 65 years, I might start by saying, have you talked with your wife about it? What could or would that conversation look like? Oh, and like Joan and Tracey are saying, oh, well, we can't talk about it with her. She won't know. She won't talk about it. This is very, very bad. It will be a big reaction. And, I'll kind of play along softly and gently with it and being like Joan saying, I think she might know. I think people do know, especially early on in stages of the varied dementias and something's changing with me. And one of the things that I've always done with my patients, with the people who are living with disease, with my own father when he was living with this illness, I would say, how are you? Crazy, I know. But how are you? How are you, the person who's living with this life-changing illness? What's it like for you? And oftentimes the response I would get from that primary patient, the person living with the illness, was, wow, nobody asks me that. And so imagine if you can facilitate a conversation with the caregiver to ask their spouse, their sibling, their parent, how are you? What do you think about this? And then exploring all of the feelings that can come along with that. And then I have the great fortune of being able to have them come back to me with all of that. And then we figure out and adjust and explore. Or I can just sit there completely with their resistance and their denial, utilizing my great motivational interviewing skills, and kind of wait for them to get to the point where they find acceptance. And I have to tell you, when they do find that acceptance, oh man, it's like a light bulb kind of going off, and to see the shift in my patients as a result, and the shift in their caregiving experience and the care receiving experience for the patient, the person living with the illness, is wild, and such a joy for me to be able to see.
I very much agree with what Joan and Molly are both messaging. And I'll just add maybe just a subtle note that in addition to, asking the questions, the first thing I do when I'm meeting a family, whether it's for palliative care or community hospice care, I just try to approach the family with a great deal of empathy. And I know that sounds like kind of like a given as social workers, but one thing I want to stress about working in palliative and hospice is if you're a naturally empathetic and compassionate person, then this is truly the right place for you. I've worked in a lot of other healthcare settings, and there's just something about the fear and the anxiety and just the vulnerability that families and patients have when they're faced with a life-limiting illness. It's unique. I've never really seen it in other settings. And hearing the word palliative care and hospice can be just create a lot of fear and anger and so many emotions. So I just start by really coming in to validate how difficult this must be. Like, let's just start there. I always acknowledge that nobody wants to be having these conversations. Like when they tell you, oh, Tracey's coming in from the palliative team, most families and patients are not looking forward to that conversation. And so just understanding that part of it. And then also, and I think Molly and Joan both said this, I have my own assumptions, of course, when I meet with a family, what their main concerns are. And I really try to be thoughtful, not to have any assumptions, and ask, what are your concerns? Like, I know what I'm concerned about when I see a family. Maybe I'm concerned about where they're going to live, who's going to be the caregiver, how they're going to get to their treatment. But their concerns might be something totally unrelated. And I really learn the most how I can best help a family by understanding what's most important to them, what are their concerns, and trying to very intentionally approach the conversation without any assumptions. Even though I do have my assumptions, I really try to just be open to hearing what Joan and Molly were saying, like just meeting them where they're at and understanding what's the priority here and then starting there.
Yes, thank you all so much. Those are such rich answers. I could see, and hopefully folks listening can hear the impact that advanced care planning can have on a family system, on a couple, on an individual. It really seems like, although very emotionally difficult, it could release a lot of pressure. It could open up a lot of conversations. And in my work, I've seen it really transform relationships, reaching like levels of connection that were never, reached before, shall I say. So I appreciate that.
Lauren, if I could just add one piece as you're
Yes,
mentioning this, I'm
please.
so
Please
sorry, but
add.
we're talking a lot about families, and I have a few patients that don't have families. And so the
Yes.
advanced care planning conversation and who's going to help with what is a complex one. I have a gentleman I work with whose wife is living in memory care. And they never had children, and he's not so close with her family. There's drama there, and he has named his niece as a person who will kind of make all the decisions for him, but he feels really bad about it. He feels like he's burdening her. He's offered to pay her for her services, which adds a different level of complexity. She, by the way, is lovely and so willing to help, and it is really kind about it. But I think it's something for all of us to consider. While the kind of the perfect package, if you will, would be if they come with a spouse and adult children and all the trappings, but that's not always the case. And then you also to consider estrangement within families. I've worked with adult children who hate their parents and have a lot of resentment because now they are tasked with, having to, or they feel as though they are tasked with having to care for their parents. So if you're a big fan of family dynamics, these conversations are rich with all sorts of different components that you'll find, sibling conflict as well. But I think it's an important piece to remember that not every older person either married and had children. And so in that case, do they have siblings? Are their siblings still alive? Are their siblings in good health? What's the cognitive state of the people who remain in their family or loose family system? And if they truly are a person who's aging in place without people, how do you help them to have these conversations with neighbors, doormen, if they're in, I'm thinking of New York City, or religious leaders, other people, so that they're not so alone? Because that in and of itself can keep somebody from wanting to have these conversations. If they feel as though they have just no one to have this conversation with, they kind of just like put their fingers in their ears and say like la la la, I don't want to deal with it. And so this is where I think we have a lot of power in being able to create a kind of good next step for all of them.
Absolutely. Thank you so much, Molly. That's such an important point. It's no surprise to anyone here that we're all living longer with all of our things, right? And that means, as Molly stated, family, connected family, chosen family, just complex family systems and relationships across the lifespan. So for social work, it's incredibly important for us to navigate that and empower the individual client that we're working with, whether they have a support system or not, to also consider advanced care planning in whatever way makes sense for them, and to start the conversation wherever they are in their work with you all, which is really setting us up for Lori and our goals of care conversation around some new legislation in our state. But I just want to say that it's incredibly important. Never assume that there are people available and willing that are connected to our clients, and always ask what the nature of the relationships are and how someone in their lives should be included. How should they? Those good open-ended questions. Sorry, my professor cap is on. So last question, I'm skipping around and I know we don't have too much more time, but I want to ask, I think this is an important question. How do you take care of yourselves? Because as we shared, this is impactful work. It's emotionally charged work. We're approaching people with all different types of experiences and histories and understanding about advanced care planning. We're myth busting, we're educating, we're emotionally validating and supporting. We're doing all the things. But how do you care for yourself as social workers in this area of practice, and reflect on your own feelings about death and loss and change, while supporting others in the role? I think that's particularly something that I know you're all constantly reflecting on in your work. And so, yeah, we'd love to hear about that.
Well, okay, I'll go first. I would
Thanks,
say
Tracey.
that I would say that what really helps me, and I work in hospice and palliative care for about 15 years, and I came from an oncology background, which kind of naturally drew me to hospice and palliative care. But what really helps me to sustain myself in the role and feel ready to come every day and face these tough issues with patients and families is my team, my peers, my colleagues, especially my social work colleagues. And if you have an opportunity to get into peer supervision with a group of social workers who are doing similar work, I really recommend that. And even like me being a part of the COIL group and getting on Zoom meetings with Katie and you, Lauren, and I find that I'm really fulfilled and kind of re-energized to get back out there when I'm hearing all the wonderful guidance and feedback from my peers. And this is another example of that, this presentation we're doing today. But just week to week, I have a group here. We all meet. We bring all of our difficult cases and we kind of pull them apart and see, you know, what worked well, what we could have done differently. And I always know that I have people here supporting me and it is social work for the most part, but I know I have here we work with a medical interdisciplinary team. So I have the medical staff, the doctors, the nurses, the nurse practitioners, and also we have spiritual counselors, we have wonderful volunteers. So just a network of people who are working in the same environment, and we are all kind of able to support each other through the difficult or the ups and downs as things are evolving with our families here.
I'll speak to this, and for me, there's a very personal aspect of this that is, a yoga and meditation practice that has really sustained me through my social work career, but especially through working with death and dying. Eastern philosophy tends to look at life and death on a continuum a bit differently than sometimes we in the West, who tend to be a little bit more death denying. I think for me, it helps deal with death anxiety. There's times where having rituals around our work can be really important and impactful. And I'm going to agree 100% with what Tracey was just saying about colleagues. Interdisciplinary team can be really important in a hospice setting. Having those rituals together can be really important at times. And I found for myself sometimes intentionally making space to process in whatever way I might need at that time. And it doesn't always look the same. I remember particularly, early in my hospice career, the first time with the pediatric loss, and I just personally needed to go and sit by running water. And I couldn't tell you why, but it was a healing. For me, it was a healing activity. So I think we need to share with each other what works and know what our own self-care practices are when we have these hard conversations day in and day out with people and deal with difficult things in our work.
Mm-hmm. I am an island. I work in my house by myself all day as a private practitioner. And so it's interesting, but can be very isolating work to do. I feel that in the 20 years within my career, I know my limits, I know my boundaries, and how I care for myself has evolved. Whereas when I was younger and living in the city, it might be going out to drinks with friends, and I had my support groups with support groups like my colleagues support groups over wine, and that was fantastic. And then I was, working out, and having that fitness component was really great for me. I need to get the energy out. Now on my island here, I have a day off on Friday. I just choose not to work, I have the flexibility to be able to do that since I make my own schedule. And that is gold. That is the day that I can do whatever I want or nothing at all, that I don't have to commit to my spouse, my children, my patients. It's solely for me. So I'll usually get a facial. Or go to the beach or something along those lines. And that has made a world of difference for me because this is really heavy work every day. And doing this as a private practitioner without having that built-in interdisciplinary team or, water cooler chatter, it's finding that time for myself. I also find just redirecting at the end of the day, as soon as I'm done with patients, I have to go pick up my small children. And then there's no time to think about anything until you're like done making lunches 7 hours later. And then you just go to sleep. So having small children has been a fantastic distraction. And also, I have a few people in my practice, about I think a quarter of my practice have nothing to do with caregiving, death and dying. It's just these they're lovely young women in their 20s and 30s who are figuring out life. And that's quite refreshing in balance to my older adults. And so if you are in private practice and can figure out that balance in your calendar, that's also really nice.
Yes. Thank you all so much. I really appreciate this. At the School of Social Work, we're talking about self-care pretty regularly with our students. And I think that sometimes it could come across a little fluffy in the sense of like, you know, as some of the activities Molly mentioned, but it's really more so just figuring out what preserves you, what renews you, and recognizing that even if an agency or a job or even patients or clients expect you to not need that, that you must take that for yourself. You must dedicate the time to yourself, away from practice, away from things, so that you can show up on Monday just as you want to be, and practicing the way that you'd like to practice with the clients that you're serving around these very impactful issues. So I hope that the students, especially in the room, are hearing that. So thank you all so much. Thank you to our panelists. Really, truly excellent work. I continue to learn from you, and I'm so glad to be with you. We're at the point now in our time together where I'm going to go ahead and invite Lori Feldstein, who is going to do a special guest presentation on some new palliative care benefits that the organization called Goals of Care was responsible for leading in the state of New Jersey. It's all very exciting, and I always go like this because it's just a tremendous win, and I thank you so much. So thank you, Tracey, Molly, and Joan, ever so much. We're going to return back to you for our Q&A. I appreciate you, appreciate everyone here. And now, Lori, we're going to queue you up. And I'm going to look back to Katie for tech. Do I have to do anything? No. Okay. All right. Thank you. And everyone is so appreciative. And we look forward to returning back to our panelists for our question and answer. And now we have Lori to share some exciting information. Thank you so much.
Thank you so much. And Katie, Lauren, thank you for inviting me to be here today. I really appreciate it. I'm going to go ahead and share my slides. So give me just 1 second to do that. And hopefully you can all see my slides.
We can see.
Okay, terrific. So give me just 1 second to put it into presentation mode. Okay. Great. So I wanted to, I'm going to spend a couple minutes, as Lauren mentioned, to share with you some information about a new benefit that is coming to New Jersey that is going to provide for a Medicaid benefit for community-based palliative care. And specifically today, we want to highlight and talk about the role that social workers are going to play in this brand new and really important benefit. But I wanted to start by introducing myself. And I have to say, after listening to Molly and Joan and Tracey speak, I had a really major if only moment. My story is one in which I did not have the benefit of having a Molly, a Joan, or a Tracey in my life at the moment when my family really needed it. So I am here today in my capacity as the CEO and Executive Director of the Goals of Care Coalition, but I wouldn't be the CEO and the Executive Director of the Goals of Care Coalition if I didn't have a personal family experience as the daughter and ultimately a caregiver for my dad. So the right side of my slide here, you see my very active 79-year-old adventure-seeking dad. These pictures are of the last vacation we took with my father to Costa Rica. And you can see him ziplining and whitewater rafting with my family. So my dad was the type of person who loved nature, loved the outdoors, loved being with his family. And these pictures were taken 1 week before my father was diagnosed with metastatic melanoma. My father lived for 11 months after this picture was taken, but he spent nearly 200 days in the hospital after these pictures were taken. And I am quite sure that if my father had had the kinds of conversations that, Molly, you talked about, that you had with caregivers and with older adults about what matters to them, if somebody had introduced a conversation, Joan, about hospice, like you did with your patients, if somebody had talked about the kind of support, Tracey, that you talked about with regards to what could be offered in the community to support my father as he went through his serious illness journey, I am quite sure that those 200 days that my dad spent in the hospital, he would have preferred to have been at home. He would have told his doctors that he would have rather spent time, he wouldn't be able to be ziplining. He wouldn't have been able to have been whitewater rafting, but he would have loved to have gone for a walk in the woods behind his house, preferably with one of his grandchildren and, sitting on his favorite chair in his den watching the Giants, even if they were losing on a given Sunday afternoon. But we didn't have those conversations. And so I sort of set out after surviving and coming out of the other end of that experience, knowing that we really ought to be doing better by patients and families who are experiencing serious illness in the state of New Jersey. And I began a journey to find other people in the state who were already working in this space, and was very fortunate to come across some of you who are on this call, some of my friends who really schooled me in what the state was already doing to try and improve care for people with serious illness. People like Tracey Grafton, who are on the phone on this call today, and Emily Greenfield and others who've been working to try to address the major gaps that we saw across the state in how we talk about serious illness, how we have conversations with patients and with caregivers about what matters to patients and how we align care to be able to deliver care to patients that really aligns with patients' values. And so together with people who had already been working in this space, we created the Goals of Care Coalition. And our focus has been in three main areas: in research, in using that research to develop policies and to really advocate for improved policies for serious illness care, and ultimately to educate both the provider community and patients and caregivers about the benefits of palliative care and about improved advanced care planning and end-of-life care services. I Our coalition is made up of a number of different, today more than 40 different organizations across the state, of which the New Jersey Healthcare Quality Institute and Rutgers School of Social Work were some of our first members, but our organization continues to grow. We are representative of all of the different associations that represent the interdisciplinary teams of providers who care for people with serious illness. And so it is because of the credibility of all of the organizations that are part of the coalition that we have been successful in our advocacy efforts. And so what I'm here to really talk to you today about is how we were able to be successful in generating policy change and what that policy change means to social workers moving forward and what it means to patients and families. This conversation around improving serious illness care matters a lot in the state of New Jersey because we've got a lot of older adults. This is not true just in New Jersey, of course, this is true across the country, but we are seeing an incredible increase in the number of adults age 65 and older in our state. That will continue to grow. They will be a significant percent of our population. And people 65 and older are not dying. These patients are living, sometimes for many, many years with serious illnesses or chronic and complex care needs. And they are often relying on emergency services or hospitals or even skilled nursing facilities, and that oftentimes conflicts with what their preferences are. So we need to do better by patients to help support them living at home and remaining in the community. And fortunately, there is a new model of care that exists that is demonstrated to in fact deliver a high quality of care, person-centered, that also reduces the cost of care, and that is palliative care. So it has been demonstrated in many robust studies to reduce the cost of care, reduce healthcare utilization, and improve patient outcomes, meaning patients are satisfied with this care. And in fact, patients who receive palliative care live longer. It is undoubtedly a patient-centered, high-quality care model that we are really thrilled is coming to New Jersey in a big way. All of the data that we had packaged together and brought to legislators was really the impetus behind the governor signing a piece of legislation that mandated Medicaid in New Jersey to reimburse for a comprehensive set of services known as our palliative care program, beginning in January. This is really, really groundbreaking because we are the third state in the entire nation to offer a palliative care program under Medicaid. California did it first. Hawaii launched their program about a year ago, and New Jersey will be the third state in the nation to cover community-based palliative care under Medicaid. And now I know what you are all thinking. We all read the news. We know that 2026 might be the worst possible time to be launching a new Medicaid program. However, because we know this program is one that actually saves the state money, we have been assured that this program, first of all, is fully funded, and second of all, has robust support within the leadership of our Department of Human Services. We are also, of course, facing a governor's election tomorrow. And, you know, there is the potential for a slowdown of progress with regard to implementation, but this is a law, and we fully expect the Medicaid program for palliative care to roll out in 2026. So fingers crossed, this program is on track. And as I said, I have every expectation and am hopeful that this program will roll out early in the year, in 2026. So I just wanted to pause for a moment. I can't see all of you on the screen because I have the slides up, but I'm not sure how many of you or how familiar all of you are with palliative care. So I just want to take a moment, maybe some of you can pop into the chat what you think palliative care is, and I'll take a moment to kind of look into in the chat, just a word or two what you think palliative care is. And while you're doing that, I'll go on just to not hold us up because I want to have plenty of time for Q&A. But just think about it, a word or two what you think palliative care is. And I'll go ahead and describe. Lauren, if you want to read out a few words, I'm sure that people are getting it, or at least some of it.
Yes. Symptom relief, care that focuses on a person's comfort, care that is meant to reduce pain, goal-aligned care, emotional support.
Excellent, excellent. So I don't need to spend too much time on definition, but I do want to just point out a couple of things. So palliative care is specialized medical care. So there are physicians, nurses, and social workers who receive specialized education in palliative medicine. And you are right, it is comprehensive in that it does provide relief from stress and symptoms. It does provide pain management. It is delivered by an interdisciplinary team of providers, including physicians, nurses, social workers, chaplains. So there is also that spiritual component. It is considered an extra layer of support, and it does provide the medical, social, and emotional support. But one of the big cornerstones of palliative care is also the care coordination. And I think a lot of the stress and distress associated with serious illness comes from the need for care coordination. Our system is so fragmented, and that care coordination adds an additional burden on top of serious illness that families often really struggle with. Another key thing I want to just make sure we don't miss is that palliative care is tailored to each individual patient's need, and it is appropriate at any stage and at any age, and it can be provided along with curative treatment. One thing we know most patients do not understand is the difference between palliative care and hospice care. So I said earlier that patients who are dealing, especially older adults who are dealing with lots of complex care and chronic care needs, are living. They are not dying. They're living often for many years. And it's those patients for whom palliative care is appropriate. Hospice care, of course, is for patients who are dying. They have to have a prognosis of 6 months or less. And of course, hospice patients are giving up curative care. Not true for patients who may be eligible for palliative care. And so it's important that we make that distinction for patients, that they understand palliative is not end-of-life care. All hospice care is palliative, but not all palliative care is hospice. When we've done a lot of work with patients and just the general public to try to understand what people think about palliative care. And one of the big misperceptions we see is that people think palliative care is only for people who are dying. When we talk to people about palliative care, they say, not for me. That's the gateway to the grave, and I'm not interested. So we've got a lot of work to do to educate patients, and that is a role that social workers can play in helping to teach the public about what palliative care is and what its benefits are. We did a study, the Goals of Care Coalition of New Jersey did a landscape study to help us understand where palliative care is being delivered in New Jersey and where it's not. What we learned, as no surprise to, I think, many of us on this call, is that there are tremendous
Oh, apologies. It looks like our speaker is just experiencing a little tech delay right as they were about to share such critical information about our state.
Maybe in the meantime, while we're waiting for Lori to pop back, we can, if anybody had a question for our panelists, we can do a quick question while we're waiting for Lori. And you can either unmute your microphone or type it in the chat. If you don't feel comfortable asking it publicly, you can private message it to me and I can answer it. I can ask it anonymously.
Yeah, and I think that they'll just, Lori's probably signing out and signing in.
Mm-hmm. Yeah, go for it, Noni.
Good afternoon, everyone. I just wanted to come on just say thank you to the panelists for all the work that you do. I used to work in hospice. I'm now in palliative care. I'm a Rutgers alum, the aging and health certificate alum as well. And everything that you guys said is what I see every day working with my patients. So thank you guys so much for all that you do.
Thank you, Noni.
Thank you so much.
Oh, here's Lori.
I'm sorry.
That's
I'm
okay.
in a hotel and I think something happened to the internet. Sorry. Am I with you now?
You're with
Mhm.
us, and you're about to drop some really important news about our state.
Yes, so I am going to share with you a little bit about the benefit itself so you understand where you guys fit in. So hang on just a sec. Let me get my slides back up. And these slides were provided by the Department of Human Services, and they are preliminary. So I'm just going to ask for you to recognize they are preliminary and a bit confidential. So we'll keep them. We'll just keep that in mind. Okay. The goal of the benefit, of course, is to improve quality of life for patients, and the benefit is, of course, intended both for adults and children with serious illnesses. You see some of the specific illnesses that patients would be eligible to participate with any of these types of diseases. But in addition to having the serious illness, they would also have to have some specific symptom burden, as in some evidence of functional decline, perhaps have been in the hospital within the last year, or have had a visit to the emergency room in the last 6 months. Of course, if they meet other criteria and it is determined by the managed care that they participate with that they can be eligible, they would. But I want to spend a couple of minutes on the covered services, because here is where the social workers really have an important role to play. We talked at the prior session in the panel discussion about advanced care planning. Even in the comprehensive care planning piece, there are important roles for social workers to play, and the difference between before having this benefit approved and available and to when this program is available is that social workers will now be reimbursed for this service. So from a system perspective, whether you're in private practice, whether you are as part of a team that is providing this service, your service will be reimbursed as part of the interdisciplinary team. I want to talk a little bit about what that looks like. The eligible providers who will be able to participate in this Medicaid program will include a lead clinician. A social worker is a required part of the team. So you'll either have to be an LCSW, a licensed professional counselor, or a licensed marriage and family therapist. There will also be required to be on the team a registered nurse and a chaplain. Those are required members of the team. The payment for this will be under a bundled payment. So you as a social worker will be paid as part of a bundled payment to deliver the set of services that I just showed. So again, this is what the required members of the team look like on the left side. And on the right side, there are additional team members, grief counselors, and others that can be brought on as necessary. In the Q&A, I can answer some more specifics about this, but I just wanted to note that for the first time, social workers, as part of the interdisciplinary team, are going to be reimbursed for the services you've long provided in terms of advanced care planning, care coordination, and support, daily support for the patient and caregiver. Some of the work that it is expected that social workers will be providing, which is much of what you've been talking about in the prior session, normalizing the conversations around advanced care planning and facilitating those conversations, coordinating with the other members of the interdisciplinary team, talking to patients about what matters most, and ensuring that the care plans align with the patient's goals of care. A big piece of the support for families and ensuring that the cultural considerations and emotional considerations are part of the conversation, again, so that care is aligned accordingly, and advocating for access specifically to additional social services that the patients may need to support their wishes to remain at home safely, etc., are part of the expected role that social workers will play in that interdisciplinary team. And the benefit provides for social workers to work in different settings. So again, the benefit is for coverage of these types of services, whether they are provided in a private practice or in a community clinic setting or in a community palliative care or hospice setting. So all of the things, again, that Molly, Joan, and Tracey spoke about earlier with regard to setting, this benefit for Medicaid patients is intended to cover. And I'm just going to quickly go through my last two slides. I think, again, the skills that social workers embody make the role that they play in the delivery of community-based palliative care, particularly for a Medicaid population for whom a lot of the mistrust of the medical system is already a challenge, is going to be incredibly important, as these patients already have challenging trust building situations, potentially navigating family conflict and addressing other social determinants is a significant challenge. I think there's a lot of important skill sets that social workers uniquely bring to the team. And we are really thrilled to know that the social worker role within the community-based palliative care benefit is highlighted as one that is essential. There are a number of tools and resources that we have created. I'm grateful to Tracey Grafton on this call for the part that she played in reviewing the content for our advanced care planning continuing education certificate program, which is available on our website, to help social workers build their skills in leading and facilitating advanced care planning conversations for patients with serious illness. We have patient education materials available for free on our website in multiple languages that also can be helpful in facilitating these conversations. And I'll end there just by saying, we all have a really important role to play. I think there is a tremendous need in New Jersey. This palliative care benefit helps us get a little bit further on the way to increasing access and improving end-of-life care. But I think all of us together have the opportunity to make the change we'd like to see. And we look forward to partnering with all of you to see that change happen. So thank you, Lauren. Thank you, Katie, for inviting me. I appreciate the opportunity to speak with all of you.
Thank you. Thank you so much, Lori, for all of your work, for sharing your story, and for driving this legislation to make it a reality in the state of New Jersey. So thank you. And there's so much opportunity for social workers to be a part of and lead the change in this experience. I appreciate you and the rest of the panelists for being here and sharing. We're going to go ahead and shift into our Q&A. So I think that maybe Katie has been taking some questions from the chat, and maybe we want to start there. Are there any questions from the chat?
Just going to start with a question from the chat that asks, are individuals with IDD eligible for the community Medicaid palliative care benefit?
Yeah, and that could be Lori, perhaps. Yeah.
Yeah, so they will have to meet the other criteria. They will have to meet the evidence of symptom burden in addition to the serious illness qualification. So as long as that is the case, yes, they will have access.
And thank you so much, Rachel, for bringing up that very good question, because it reminds us all to think about our inclusivity, how, sometimes and oftentimes, ageism and ableism, the experiences of older adults and the caregiving nuances of folks living with intellectual or developmental disabilities as they age, what services look like compared to for older adults, that whole matrix. We know that there's a lot more work to be done there. So I appreciate you bringing that question up. Adrian, I'm going to go ahead and call on you. I see your hand raised. Oh no, now I lost you. Oh, there you are.
Yeah, I do have a question. I apologize for joining late. A doctor helped me up, but I as a person who provides that emotional, mental, and spiritual and practical support as a doula, not only for those who are dying, but also those who have an advanced stage illness, I always reflect back like Lori did on when my father passed away, and this was about 20 years ago, and I had not entered the field. And I remember them using the word palliative. And I said, well, what is that? And so without being an advocate, as the work I do, I was always the advocate for my family. And so they sort of explained it to me. And when I look back on it, I think that was hospice and not palliative. And so I'm always reflecting on, I remember them mention the word DNR, and I'm like, well, what's that? And my mother had agreed to a DNR, but she didn't really quite understand the DNR. And so I'm always reflecting back on that. And so my question to Lori is, I appreciate you sharing your story about your father, but I kind of want to rejoice in how far we come. And so if you could just share what year that happened with your dad, and you might have done it, but I'm also driving to my next location. I'm just curious to see what year no one, spoke to you or educated the family on the matters that you shared.
Yeah, it was 2014. And, my father was a physician. We should have known better. We should have had more of those conversations. But it was many years ago.
Wow. So that, not quite 20. And, you know, the mindset then, and I'm quite sure that he, as a doctor, he probably was surrounded around, you know, doctors who, you know, as the thought is concerned, to preserve life. But that's pretty interesting, 2014. And I did want to say, as far as the hospital where my father was in, it was a top-notch hospital in another state. So
Thank
pretty
you.
interesting.
Thank you so much, Adrienne, and thank you, Lori, for sharing a bit more about your story. We appreciate that. Thank you so much, Adrienne, for your comment as well and contribution. I see another question in the chat, and I'm also just welcoming folks to raise your hand or do any, drop questions in the chat, but so I can maintain a little bit of like timing. But Samara asked, how will people who qualify initiate services through their MCO or through the palliative care organization? I think is for Lori again.
It's a great question. And there is going to be, as you can imagine, a process for an eligibility process. So the journey will look like this. There's actually going to be a screening tool. Once that screening tool is made available, we will have it on our website. Anybody can fill out that screening tool. If you encounter a patient that you think should be considered for this benefit, you can fill out that tool. The patient and the care or a caregiver can fill out that tool. You would take that screening tool to a provider. It can be your primary care provider. It can, if you're a cancer patient, you can take it to your oncologist. That would trigger a full medical assessment. That will have to be submitted to the managed care organization for an approval. So the assessment will have to be done by a provider, by a physician, and it will be approved by the managed care organization in order to enroll the patient. And that will begin that will be the eligibility. That's how the process will go.
Thank you. Thank you so much. And Samara says, thank you too. Very good answer to an important question. A question now to our panelists. And this comes up in our work, and we might have touched base on the question, but how do you navigate conflict or differing beliefs and values when discussing specifically end-of-life preferences? This is to our panelists, Molly, Joan, and Tracey. So again, how do you navigate family conflict or differing beliefs and values when discussing specifically end of life, which advanced care planning can include all of these things, but we're talking mostly about end of life in this question. Tracey.
Oh, go ahead, Joan, if you wanted to.
No, go ahead, Tracey, please.
Oh, okay. I'm not sure if this answers the question, but there is often a lot of conflict when we're starting the discussion, and not only amongst the family members and the patient, but even sometimes amongst the healthcare professionals that are invested in the care of the patient. I see this a lot where sometimes we're seeing a patient's functional status is declining, and we want to help the family understand the benefits of palliative care and hospice. And it sometimes could be even the doctor that's been very invested in treating the patient who's really steering them to continue with more treatment in spite of the quality of life concerns that they have. So it is very complicated, and there is often a lot of conflict. One thing that I try to help people understand is that hospice is an option and palliative care is an option, but you don't have to have hospice and palliative care at end of life. And I think just helping people to feel more in control and understanding, well, what does it look like if I was to continue treatment till I die versus getting some palliative care services? What might that look like for my day-to-day quality of life versus hospice? And so just, I think the first thing I really try to help families understand is there's no right and wrong when it comes to end of life, but just giving them all the information so that they can make the decision that is best for themselves, if it's an individual without a family, or for themselves and their family, if it's someone looking at a family system. But just really understanding that what's good for one person may not be good for me, and being very open to understanding what's important to them at the time.
Thank you so much.
I'm not sure if that answered the question.
Yeah, I think it did. Molly and Joan, do you have any additional points?
I think that we arrive as social workers and we listen to people's perspectives. And sometimes we can help people to focus on what their goals are. Sometimes we're helping them to redefine what hope means for them at this stage in their process. And sometimes we're helping them to deal with the real losses that are going on in real time. Because often there's so much loss for each individual person involved. And addressing those losses, helping people to feel heard can be a really important aspect as well.
So often what I will do is I usually see individuals, but I have occasionally worked with either a system, like a couple of siblings or the spouse / parent and the
So
adult children.
let's take a look at.
And so depending on what's going on, right? There are a lot of feelings that come up, and I often will recommend, if it's getting really dicey, that they refer back to the plans and the legal documents that have been created if they have had the advanced care plannings, or just provide them the opportunity to speak as a group. While I will mediate or work with a formal mediator or a family therapist or a grief support group, or all of the above, depending again how dicey things are getting within the family system. But it can be challenging, and I think it's important for all of us, whether we think we have the specific skills or not, just to be good listeners. And going back to what Tracey mentioned earlier, figuring out how we can channel that empathy. And I think what I'm not sure it has been specifically mentioned before, but today at least, or yet today, I should say, I think it's important for all of us to check ourselves and our own feelings about end of life, death and dying, what our experiences are specifically with this before we start getting involved, or perhaps overly involved, or I don't want to say inappropriate, that's not the right word, but like just not as boundaried and involved with families by bringing our own feelings to the table, especially if we are a newer social worker who might not have as much experience yet, and we're really close with the person who might be at end of life. And so kind of checking yourself and all of that and those feelings, working on it with your supervisor, working on it with your groups, with your own personal therapist.
Yes, absolutely. Thank you so much, Molly. And I just want to share one last point, because I wouldn't be a social worker if I didn't, but it's also about understanding the context in which we define quality of life. So if you're a student in one of my classes, you hear this a lot, and I apologize, but we tend to have a very medical definition tied to quality of life. And as social workers, again, sorry, but it's our duty and also our opportunity to help drive nuanced understanding about what quality of life means. And not only for our interdisciplinary team members who are so well intentioned and so want to help, but also our families, our caregivers, and anyone else attached to the person. Just recognizing that this is unique to each person, and it doesn't mean the total and complete absence of risk, for example, right? So sorry, last little point there, but one that I feel very important, especially for newer social workers and professionals now getting into this space and recognizing again that this is going to come up more and more in our practice. And we have the privilege to be able to drive change in so much of what impacts palliative care and end of life care planning. So with that, we are 5 minutes past, and I shared with Katie, we've got so much to say. It's going to be going really fast, and we might need to plan like a part 2. But I just want to thank everyone. Thank you, especially to our panelists, Tracey, Molly, and Joan. Thank you to Lori as well for all of your work and for joining us today and sharing updated information about the new benefit, the New Jersey the New Jersey Healthcare Quality Institute, COIL, Hub for Aging Collaboration, of which I'm a member of at the School of Social Work. I keep saying it's the new WIS Center. It's not quite so new anymore, but it's the new WIS Center under the School of Social Work, focused on all things aging, health equity, training, research, education for the workforce. and also our, of course, School of Social Work, and all of you for attending over your lunch break or over your time, wherever you are, we thank you. Katie, I'm going to defer to you about follow-up with
Yeah.
resources and feedback survey.
Yeah, sounds great. So I will follow up once we have the recording all together and email it out to all of you, along with resources, including what Lori has spoken about with the community palliative care benefit, as well as some resources through COIL, and then some information on COIL and what we do, and if you'd like to join us at any time. As far as the feedback survey, when you exit, there will be a survey that pops up for you through SurveyMonkey. I really encourage you to fill it out. You know, as social work students, we know how important like feedback is. So we just want to know how we can better support you in the future with different programmings and your perspective on this event. So thank you again to everybody that has joined, as well as our panelists and speakers and partners today. So thank you. And I'm going to stop recording. There we go.